So, good afternoon. My name is Dr. Mary Doherty. I am a liaison psychiatrist and I'm the clinical and strategic director of the College Centre for Quality Improvement. And I'm delighted to open this webinar today. This is our first webinar in the Centre for College Improvement's month promoting equality, diversity and inclusion. And we've got a huge number of webinars and resources and interactions planned. I wanted to mention briefly what the CCQI is, because we've got a wide range of people registered for these events. This is a department in the Royal College of Psychiatrists that's about improving quality, and we use a number of different methods to do that: national audit, our prescribing observatory for mental health, and also our quality networks and accreditation schemes, of which we've got over 26 and over 1,600 members across the UK. Nearly every mental health provider in the UK is a member of one of our networks, and we've got a huge range of other members across charitable sector and secure services. So it's fantastic to see such a range of people registered. As I said, this is the first in a number of webinars across the month that are going to be focusing on how we can make more equitable workplaces. We're going to bring a range of topics. We're looking at inequalities that staff may experience in mental health services, gender inequality, neurodiversity. And we're kicking off today with basically sort of an introduction to inequalities in mental health. And I'm absolutely delighted to introduce you to our joint presidential leads for race equality. That's Dr. Raj Mohan and Dr. Laddie Smith. And Dr. Laddie Smith is also one of our presidential candidates for the upcoming RC Psych elections. For those of you who probably, you may have heard of Laddie and Raj, they have been absolutely pivotal in supporting the college in its strategic ambition around fundamentally changing how we approach equality, diversity and inclusion in mental health services. And we're incredibly lucky to have them here to talk to us. They bring a vast range of knowledge. So I'm going to hand over to them, but with one final bit of housekeeping that I'm always dreadful at remembering, which is please join the discussion on Twitter using the hashtag CCQIEDI, and please do feel free to submit questions, and if we have time at the end, hopefully we can put them to our two speakers. So Laddie and Raj, thank you, and over to you.
Okay, thank you very much indeed for inviting us to speak. So I'm going to essentially do a really quick overview of inequality. I'm going to focus on certain types of inequality and just explain why it's bad for mental health. Okay, so we know already that people who have protected characteristics, who have been more marginalised in our societies, have worse health outcomes, in particular worse mental health outcomes. So we know that if you're from an LGBTQ plus background, then you're much more likely to have had suicidal ideas and even attempted suicide. We know that women have higher rates of suicide and actually have higher rates of mental health problems. We know that particularly self-harm in women. We know that if you're from a lower income household, you're much more likely to have an unmet mental health need. If you are homeless, 1 in 2 people who are homeless in London have actually got a mental health problem. If you've got an intellectual disability, not only will you have a much higher risk of having a physical health problem, but also you have a much higher risk of having a mental health problem as well. And this is, the list goes on, to be perfectly honest with you. And we also know this, unless you've been, hiding away for the past few years, you should know that if you are from a minoritized ethnic community, then you are at far greater risk of being involuntarily detained under the Mental Health Act in the UK, and actually across the world. Actually, if you're in someone from a minoritized background compared to, say, a white majority background in a white majority country, you are much more likely to be detained than someone from a white British background. And that's not just for Black people. That's also for South Asian people and anyone from any other mixed background, any other ethnic background, including white other. And the problem is that if you're Black in particular, you are much more likely to be admitted, not simply admitted and detained under section, but you're much more likely to be admitted with the help of the police. much more likely to be admitted in crisis. And when you do get admitted, you're more likely to stay for longer. And when you do finally get out, if you're from a Black Caribbean background, you're much more likely to be repeatedly detained. This is really important because usually when we have a health problem, usually what happens is, and certainly if it's mental health, you go to the GP and the GP refers you on, or you can refer yourself to IAPS, and then you get some help there and the IAPS might refer you on. But in 40% of cases with Black people, actually the way in which people access health services is via the emergency services, primarily the police, and via the criminal justice system. So there's a massive overrepresentation in crisis and secure services, but interestingly, underrepresentation in treatment. Now, as I said, most of the time we'll, if it's, for example, psychological services, we access them via, GP or IAPS, for example, improving access to psychological therapies. And what's interesting is people from South Asian backgrounds, particularly South Asian women, have no problem presenting to their GP with a problem. However, they're really unlikely to be referred on. It's very hard to get psychological therapy no matter who you are. That's the first thing to say. But what we do know is that if you are from a white British background, if you're white background, then you get in more easily. And then when you are if you in fact actually twice as likely to get into psychological therapy. I mean, the rates, we're talking about like 15% of people manage to get psychological therapy who need it. So the rates are pretty low for everybody. But if you're from a minoritized ethnic background, then the rates are more a bit like kind of 6 or 7%. And when you do get in, you're much more likely to drop out. You're much more likely to drop out and you're less likely to recover. So although Black people in particular are overrepresented in crisis and secure services, very much underrepresented in treatment. Anyway, this slide is just to remind you that we actually do know quite a lot about what causes mental illness. What are the risk factors? They include things like, well, we know that genetics are important. This is for schizophrenia, for example, if you have an identical twin with schizophrenia, you have a 1 in 2 chance of developing schizophrenia. Perinatal factors, which are, biological factors, are really important. So if you're born prematurely, low birth weight, if you have a birth injury, anoxia, or hypoxia, lack of oxygen to the brain during the birth, we know that these are important factors that increase your risk. Being malnourished in the womb is an important risk factor for the development of mental illness later in life. And in fact, as psychiatrists, what we do when we're assessing somebody is that we'll ask people about their very early life, even before they were born. And we know but interestingly, although it's a biological factor, just be mindful that even something like a perinatal things are not necessarily that although they're biological, sometimes there's a social aspect to how well a person might do around the perinatal period, a psychosocial aspect. So we know from the Race and Health Observatory that, and actually from other studies, that that there are significant disparities in access and outcomes to antenatal and perinatal services for women from South Asian and Black African backgrounds, with much higher rates of maternal morbidity and mortality, 4 times higher rates in some cases. And we also know that there were higher rates of neonatal morbidity and mortality in minority ethnic groups. So this, and people are saying, okay, what's going on here? And it looks like there are issues around antenatal care and the care given during the perinatal period when people are actually having their babies. Other biological factors that are important: lead's really important because we know it increases the risk of mental illness. And drugs are really important. Amphetamines, cocaine, cannabis, all associated with an increased risk of developing mental illness. There's something about inflammation, and there's been a question mark about vitamin D. Just to tell you that vitamin D, it doesn't matter what your vitamin D levels are. It's not associated with being able to improve outcome in psychosis, although it is good for skin and heart health and things like that. And we know that because we've just done a very big study on it. We also know that other things that are really important: trauma, and it's increasingly evident that trauma, particularly in early life, adverse childhood experiences are associated with an increased risk of developing mental illness later in life. We know that traumatic events as an adult life events such as bereavement, even moving house, are associated with mental ill health too. So we know about quite a number of factors already that are associated with the development of mental ill health. However, what we don't tend to really focus on as risk factors are some of the social factors and also potentially discrimination. And the reason, and what I'm going to do today, is to show you how there's increasing evidence that we ought to perhaps be thinking of social factors, psychosocial factors and social factors and discrimination as risk factors for the development of mental illness. Okay, so just take it as given that just say very importantly, genetics are clearly important, but there's evidence that the genetics really aren't everything. Just because you have a genetic predisposition to a disorder does not mean that you are going to develop it, and other factors have to be in place often before you'll actually what's called express the disorder, if you like. So there's a question here: why is it that people in certain minority groups have worse mental health? Okay, and the social factors that are important. If you are someone who is lucky enough to have been born to parents who are sufficiently educated, very understand, can get hold of the pregnancy magazines, your mum listen, she does pregnancy Pilates, and she really eats well because they've got enough money. Both the parents they're together, they've got good jobs, they can afford really good healthy food. She puts Baby Mozart on so that your brain will grow as big as it can possibly. They swap their inner city pad for a lovely 4-bedroom house with a big garden in the suburbs. That's right next door to a really good school where the teachers care about you achieving your potential, and you're in a good neighbourhood, so that if you found wandering at midnight and you're only 9 years of age, Mrs. Jones down the road will take you back home because she knows where you live, and she knows that your mum wouldn't like you to be out, and she cares that you're out, and she knows you shouldn't be there, so she'll take you home. And in your home, whenever there's enough money so that there's always nutritious healthy meals on the table, you grow well because you went to a good school, you go to a good university, you get yourself a good job. Because you've had a good job, you're able to live in a really nice community where there's you can access a local choir, and you enjoy doing that, and there's a good gym to go to, and because you're educated, even though it's difficult to access the GP, you know how to do it and how to negotiate the system. Do you know what? You'll be absolutely fine. Even if you have a genetic disorder, like, or a long-term problem, say you had a thyroid disorder, you'll be able to manage that disorder and you'll probably be okay. Actually, you'll live a fairly long, relatively healthy life. However, what we know is that your social position in society we do have, so people are stratified, and there are some people who are just who are at the top of society, and other people who are at the bottom of society. And if you are lower down the social order, then you will be differentially exposed or vulnerable to certain conditions that unfortunately affect your health outcomes, and they may be adverse to your health or protective. And what we know now is that those conditions not only affect the way that we respond to, our bodies respond and our minds respond to the conditions, but also our health, the way in which we behave in terms of our health related behaviors, how well we look after ourselves, are also affected by what happens in our community, in our neighborhood, etc. And those factors all work together to impact on the way in which health is distributed. Our health is distributed. Now, this isn't some, think tank saying this. This is Public Health England saying this based on very sound research. This is from Public Health England 2018. Social factors that we know are important in the development of severe mental illness include parental discord, living in a very dense urban population, that increases your risk, family breakdown actually is as when you are a child. That's been associated. That's from the ESOP studies. That's a big study of first episode psychosis. But interestingly, ethnic density can be protective. So there's some evidence that if you live in an area where there are lots and lots of people who are like you, that reduces your risk of developing mental disorder. Now, this slide I always show because it's really key, and it's basically showing household wealth. And if you look at the household wealth, this is by ethnicity. Now, if you have a look at the blue bars, this is the median, okay? And this isn't exactly how much people have got in the bank. This is basically how much money, you know, how much assets people have. This like includes their house. And you'll see that the people at the bottom of the chart are the richest people in our society, and it's no great surprise that there's people who of white British origin. The people at the top of the chart are the poorest people, and they are a fifth to a sixth poorer than the people at the bottom of the chart. And there's Black Africans and Bangladeshis and Chinese people, actually. Why is this important? It's important because, well, a couple of reasons. Number one, if you live in a deprived area, which is much more likely if you are poor, you will spend 1/3 of your life in poor health. If you live in an affluent area, you will spend only half of that, 1/6 of your life in poor health. So take someone like South Kensington, you know, we've all heard it, it's very posh. That's where the Victoria and Albert Museum are, lovely stucco fronted houses and all the rest of it. The people are very wealthy. The life expectancy of a male born and bred in South Kensington is about, it used to be kind of 82, 83. It's gone down a bit now. Everyone's life expectancy has gone down a bit. Call it 80. Yeah. If you live in North Kensington, a few miles up the road, and it's a very deprived area, your life expectancy is up to 10 years shorter than the people in South Kensington. Now, what does that mean? Well, that means that you are much more likely to die when you're about, say, 70 rather than 80. It also, think about it, now that pension age is, you know, 67, ouch, it means that, you know, you're 67, you finally get to retire, and a few years later you die. But not only that, in the years leading up to you retiring and then dying a few years later, you will have been living with some kind of long-term chronic condition, probably from the age of about 45, emphysema, say, or a mental health condition, you know, chronic severe depression. That's what it means. It means that the latter part of your life, you'll be living in poor health, and then that poor health is likely to kill you at an earlier age. Oh, the other thing to say about this is this. When we look at data, and this is really important, you notice something, that we've got, we tend to have a habit of mushing everyone together, you know, particularly in ethnicity, when ethnicity data's, you know, reported. So there tends to be a tendency to lump together people from South Asian backgrounds. So South Asian gets lumped together, Black people get lumped together, and the difficulty with that is this. Now, remember what I said about people being poorer, and you'll see that the Indian people who match the wealth of the white British people are actually, look at that, Indian people down here. And it means that it's much more likely that these people will have better health outcomes than the people at the top of the graph, for the very reasons I said about poverty. The people at the top of the graph include Bangladeshi people, also of South Asian origin. Bangladeshi people have far worse access and experience, and really far worse health outcomes. That's important because, I mean, you sort of think, why might that be? Well, it's probably to do with the history of the type of migration. And people from Indian backgrounds, in the 1980s, 1 in 20 Indian men in the UK was a doctor. And that's because India has fantastic, you know, medical education. It's very similar to British education. And so it's easy to attract people and say, come over and we'll pay you lots of money. And of course, people came over highly educated and they came straight into well-paid jobs. Compare that with people who were coming in the 80s from Bangladesh, often escaping war, famine and flood. They were coming to seek asylum with nothing on their backs. And what's happened is that people have managed to, establish themselves, get jobs, run restaurants, become doctors, whatever. But there still remains some of that intergenerational trauma because they've had a much reduced place to have to work up from compared with people from Indian backgrounds. The problem is this: if you lump everybody together, then if you like, the success and the more positive health outcomes for the Indian people will mask the poorer outcomes for the Bangladeshi people. And this is just to remind you that being rich doesn't stop you from developing a mental health problem, but it does help. And you can see that rates of any mental disorder are much higher, almost two and plus times higher in people who are poorest in our society compared with the richest. And you can see this in a regional way as well. And in fact, look at this. This is Northern Ireland, Scotland, Wales, England. And it's a shame they're not all the same colour. But basically, the darker areas here are where the poorer people live. And interestingly, this is predominantly Catholic areas because they were excluded from certain types of jobs over time. North Scotland, South Scotland have poorer rates. South Wales, these are where all the deprivation is. And in England, look at that. The darker areas here, dark blue, this is the areas of deprivation. Look at there's a very significant north-south divide. And then there are pockets of Cornwall, little bits of Kent, Thanet, which are real problems. Now, why is that important? Just take a mental picture of that the levels of deprivation in England. Now, look at that. This is a map of England with depression and anxiety prevalence, and you can see that the areas where there's more depression and anxiety map almost directly onto the areas where there's more deprivation. And the thing about these, and look at that, there's Thanet there, okay, sticks out, it's very poor. And the thing is that these areas of deprivation are the levels of depression and anxiety are twice as high in the areas, these areas where people are more deprived, as they are in the less deprived areas. Okay. All right. So just very quickly, discrimination. There are 3 types of discrimination. And individually mediated, can be covert, overt. This is the stuff that everyone thinks of when they think about discrimination. And this is when people, get horrible racial slurs thrown at them, or there's some horrible sexist thing that's said to someone. It's really obvious, and everyone thinks, oh, that's terrible. Everyone can recognize it. Yeah. And just to say, it's now known that it does have it results in a physiological response, very negative response actually, and that can have an impact on people's physical state. The bit that's a bit harder is institutional or structural discrimination, and people don't fully understand this so well. This is Kamara Phyllis-Jones's definitions, and essentially it's a kind of differential access to goods, services and opportunities by race, sex, gender, religion, disability, etc. And it manifests as an inherited disadvantage. It's kind of codified into our customs, practices and laws. So I always say, if this was 1822, there's absolutely no way that the person giving this talk now would be, that Dr. Smith giving this talk would be female. Dr. Smith giving this talk would definitely be a male. And that was because everybody knew that women couldn't be doctors. You can't be a doctor if you're a woman. And the reason you couldn't be a doctor if you're a woman was because it was well known that if women were too educated, women's brains would swell, their ovaries would shrink, they'd become infertile, they'd become infirm, they'd get very ill and probably die. And that was thought to be a scientific fact. And Henry Moseley believed that women weren't capable of being educated, and it was absolutely outrageous that everyone would consider such a thing. Any caring, loving parent would, when little, Sally Ann asks, oh, please, could you, I want to be a doctor. That any caring parent would say, absolutely not, darling, it'll kill you. And it just became, and after a while that all gets forgotten, it just became common knowledge that women can't be doctors. And so it went for many, many, many years, actually. it means that it became something that was just kind of codified into our customs, practices and laws. It's just the way it is. If you would try to, Elizabeth Garrett Anderson applied to medical school and they laughed at the very idea. How could she be thinking of this abnormal woman? What's wrong with her? The thing about this kind of, we all just are just so used to it, just the way it is. There's often no active perpetrator, but it can result in inaction in the face of need. Just like when there are people in wheelchairs who literally couldn't get into a restaurant because there were stairs up to the restaurant. Those of us sitting in the restaurant, able-bodied, had no idea that there were people in wheelchairs who would like to be in the restaurant, just thinking, oh, you know, it didn't even occur to us that there weren't wheelchair users in the restaurant. Okay, because we're just so used to it. However, what was needed were ramps and escalators, and eventually that happened, and now you see wheelchair users in restaurants, but we didn't notice it before. There's often no active perpetrator. Okay, and just very quickly, internalized discrimination. This is the doll experiment, Kenneth and Mamie Clark, 1940s and 50s, and what they showed was, this is, you know, they took a group of year 1 kids, 6 and 7 years of age, a group of black kids, a group of white kids, gave them a white doll and a black doll each. And they said, which is the good doll, the funny doll, the doll you want to be friends with, the doll that the teacher likes, the doll that's going to do well in life? Which doll's the bad doll, the naughty doll, the doll you don't want to be friends with, the doll that gets told off by the teacher, the one who's stupid? And of course, all the white kids said that the good doll was the white doll, and all the black kids said that the good doll was the white doll too. And what Kenneth and Mamie Clark said is that, look, we're all subject to these ideas and prevalent kind of stereotypes that exist in our society. Everybody is. And that results in acceptance of the negative assumptions and stereotypes about abilities and intrinsic self-worth, and it involves the devaluation of the self. And that can result in colorism. So you stratify people by colour. The darker your skin, the worse you are. The lighter your skin, the better you are. That happens in the West Indies. It happens in India. And that can result in people thinking, what's the point bothering? You drop out of school, you don't vote, you engage in risky health behaviours. I'm not going to go into it, but I'm just going to say to you, have a look at the blue eyes, brown eyes exercise by Jane Elliott. Primary school teacher, she separated her kids into those with blue eyes, those with brown eyes. She put the brown-eyed kids in charge. Go and find out what happened. The impact of racial discrimination is, Geronimo said, this causes weathering. Eventually, that gradual drip, 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 drip takes its toll on people's health, physically and mentally. Robert Carter said, actually, that drip, 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 eventually, I mean, that drip is a psychosocial stressor. It's an emotional trauma, and that can cause almost symptoms like post-traumatic stress disorder or anxiety, depression, suicidal ideas, etc. So we don't know if that's definitely the case, but there's some evidence increasingly that actually discrimination does have an impact on people's mental health. And there are a number of studies that show that, and not just racial discrimination, but sexist discrimination, homophobic discrimination have been shown to, unfortunately, affect people's mental health. And then finally, why is it that if you're marginalised, just because you're marginalised, why should you have worse outcome? Once you get into care, why should you have worse outcome in care? And it's likely because most of the interventions that we develop and the interventions that we test on are developed in usually Western models and usually trialled on college students who are predominantly men and predominantly from white European backgrounds. And that means that we then extrapolate the results to everyone else, to women, to older people, to people of different ethnic, racial and cultural backgrounds. And so it might mean that we're only really catering for a group of people, not everybody else. And so the treatments might not always work so well. And this is something that Carla Buckhard and her colleagues came up with. They talked about the Western educated, industrialized, rich democratic societies. And they said that these societies are only about 12% of the world, but they generate all the answers that we, you know, all the work. And that's a fantastic thing. But those theories and the insights and interventions might not apply to everybody else. So we have to find a different way of doing it, which is about cooperating and collaborating with people in other parts of the world so that we can have a richer, more diverse answers to things. Okay. So it does mean that if you're from a weird society, you're more likely to get treatment that works for you and everyone else doesn't. The problem is if you don't attend to that inequity, then it might result in a perpetuation of those kind of institutional and structural discriminatory factors, because it doesn't help those who need it actually, and that can actually exacerbate mental health inequality. And you know, so the idea is that in research you kind of try and promote and prioritize equity. Actually, I'm just going to quickly just remind you about something. Actually, it's about structural discrimination. Here we go. Very, very quickly. The policies that we put together can inadvertently cement in discrimination. The one baby policy in China, this was because China was starving, and the Chinese government said, you just got to stop having so many kids. And so they said to everyone, you can only have one child. And what they didn't take into account is that people thought, well, if we only have one child, I only want a male child, I don't want a female child. So Chinese people basically got rid of their female children, either by abortion or in many cases just adopted them away. So if you know someone who's adopted a child from China, that child will be a female child. The problem is that policy resulted inadvertently in 50 million women being missing from mainland China. So this is Amartya Sen's work. And what it means is that there's whole provinces of China where there just aren't enough women. So women going through those provinces sometimes get kidnapped by families because the families need a woman to be able to continue their bloodline. Anyway, that's kind of what can happen when you have a policy, the structural policy that inadvertently discriminates against a group of people. Anyway, finally, excessive rates of mental disorders seen in people who are socially disadvantaged and discriminated against. It's not simply about the genetics and the biological factors. To some extent, it's likely that the excess rates are because of social disadvantage and discrimination. And what we need to be doing now is to really look at the adverse factors that engender that, as well as protective factors that might reduce the risk of that. Certainly, I think that addressing structural inequality earlier might mitigate some of the risk factors for mental health later in life. And as psychiatrists and everybody else who's working in the mental health field need to be alert to this and to work to combat structural inequality and discrimination, because I think that will certainly help to improve health outcomes for certain patients. As Michael Marmot said, health inequalities and social determinants of health are not a footnote, they are the main issue. Okay, thank you. I'm going to hand over to Raj, who's going to tell you what we can do about it. Thank you.
Thanks so much, Lali. I'm going to try and get my slides up. Just to quickly check, can you see those slides? So I'm just hoping that you can see the slides, yeah? Can you confirm, Ladi? Or
we can see them, Raj.
Okay, fantastic. So thank you, Ladi, for taking us through a whirlwind tour of how discrimination, inequality can affect mental health. There's so much evidence out there, and you've summarized it so neatly. So I'm just going to take you through a similar broad overview of what things can be done, what can be done by individual clinicians, and what systems can do. And also think about why things haven't really worked out the way we intended them to. First and foremost is to be aware of the impact of inequality on mental health problems that we have. When you look around you, you see more and more data showing inequalities. There's so much data which you start examining in more detail, you actually see what the patterns are. You realize that it's not okay to have unequal care. It's not okay to be unfair. So we have an ethical and moral imperative. We have equality legislation, but we also realize that it costs us a lot of money to have an unequal system because there's more illness. You also know that there's much more awareness, but with a cash-strapped healthcare system, you really need to think much more about prevention and sustainable recovery. We can't have people getting ill and coming back into hospital again and again at all. So it is about the frame of mind. You are in a space where you want to bring about change. So that's your motivation too. So I would say, I don't need to go into this. There's so much inequality out there all across medicine. death rates of Black women in childbirth is absolutely scandalous, and it hasn't really improved that much. You also know deprivation on its own. It's not a protected characteristic, but it causes significant problems, and government policy may exacerbate these things. So I won't go into it, but it is about actually getting hold of data, not just any old data, but make sure that your data is disaggregated so that it tells you about different populations in your area. So if you have Gypsy, Roma, traveler community in your area, try and find out something about them, because if you don't know, you can't help people. Then there is an issue about what we already know, and the question, why hasn't something been done? Okay, what stopped us from doing things? So this is about housing inequalities. This is from 5 years ago, when they looked at unstable housing, or people living in overcrowded housing, for example. This is data from East London showing Black, African and Bangladeshi residents were 3 times more likely to live in overcrowded housing. But if you think about COVID, they had very high risk of dying because of the illness, because of the virus, and it could be to do with overcrowded housing as well. So why didn't something happen? Why didn't something change? That is a really important question. Okay, why don't we put action things? So when we were writing and researching for the Royal College's Equality Action Plan, we looked at why old reports didn't get implemented. There are a number of things emerged from that. People didn't really know the data, they ignored findings, or they didn't look at it in any great detail. Then people who actually saw the differences didn't have the expertise in doing something about it. When they wanted to do something, they were not using a system, they were just using some measures, but there wasn't a program for it. Then there's always something else more important. There's financial problems, so equality actually doesn't come to the top of the list. Lastly, leadership is an issue, and it's an essential requirement, and there should be accountability. So hopefully, by addressing the barriers, you would be more successful in implementing a program. So I don't need to tell you anymore about the different protected characteristics. There are 9 of them, but also you have protected characteristics such as being homeless, or being looked after child, or being part of a traveler community. All these things add extra barriers into your healthcare access. So make sure that your data, as I said before, is disaggregated and actually useful for you to make a change. The other important thing all clinicians and organizations really need to be aware of, there is something happening which actually is about denying that there is such a thing as structural racism, and that is clearly explained it. And I'm going to say that the structural racism hides in every system, every policy, every structure that we've created, and it has an impact on people, and it's a differential impact. Women could not vote for a long time. Black people had so many aspects of their liberties taken away, but this tends to perpetuate itself. If you look at the people in in public schools, for example, or people who become prime ministers, you just see that there are differences, and certain people are always likely to be excluded. So we have to look at the evidence. When these reports come out, we have to actually call it out. I think it's absolutely essential. If you work in mental health or any field of health, you do need to call it out. This is a quote from Michael Marmot, and you just saw one in Ladi's presentation as well. Inequities lead to health problems. That's absolutely how it is. It does so because it affects how you live your life. So essentially use the evidence that Michael Marmot has provided, put that into practice. So this man has dedicated his entire life for this work. Please, make sure that you make use of it. And understanding equity is really, really important. It's not always well understood. So I'm just going to read out what's in yellow there. Health equity means that everyone should have a fair opportunity to attain their full health potential, which basically means that there should be no barriers to access to healthcare. So this concept is so crucial. We don't think about it. We think about people who come in through our door to see if there is a difference in how many white people or young people or women come through to the clinic, but we don't think about all the people who don't come in and why they haven't come in. And that's just really the thinking you need to do. This is a graphic we created at the Royal College, but there are other versions of it. Equality means everyone's given the same resources to progress. Equity means that each person gets the resources that they need to progress. So it's different. When everyone has equal opportunities or there are no barriers, then you don't need to make any adjustments. It's all going to work out well. So this is a concept we need to understand. In medicine, we get it really well because somebody with very severe pulmonary edema will get a different treatment to somebody with another form of respiratory disease because it's all tailored to what people need. It's not that everyone's given the same medication or the same antibiotic, for example, and we're good at this. And that's really the concept here. It's not always well understood. And Ladi also said about structural racism, and I just want to kind of take you through the process here. Whenever you see health inequalities in your clinical practice, for example, differential life expectancy or rates of maternal mortality, you start thinking about what are the social determinants of this particular difference. For example, it's poverty, inequality, housing, lack of jobs. What is driving this particular inequality? And then you think, what is driving that social determinant? And it's usually a structural factor. There will be policies and things that prevent people from accessing the resources they're entitled to. So it's such an important thing. The question people may ask is, what can you do about it as an individual? That's less important than factoring in the exact causes of why that person became ill in this particular way at this point in time. It's a part of our formulation. So understand, the things that played a role. We, for example, try and understand trauma much more than we used to. And this is very similar. Racial trauma comes into this too. I would say, these are really good clinical practices. For example, you always make shared decisions with your patients about what treatment they should have, what diagnosis they should have. This is because if you ask people how to do things, you will actually reach a better decision. There's no doubt about it. Secondly, person-centered care, everyone talks about it. But if you really think about what that person needs, and then the entire care process is situated around what the person's real needs are, properly assessed. For example, housing would occupy a much more important position there, and not as an afterthought. So these things, when practiced well, can make a difference. It may reduce some of the inequalities because each individual's need is considered. So that's about personalization of care, where you take into account all the social factors. And people have started talking more and more about co-production and co-design. And the important thing to remember, if you design a service, you always ask people or design it with the help of people who will be using the services. Otherwise, they won't turn up, they won't benefit from it, and it's not a good scenario. Your service is likely to fail. So co-production basically means about doing things with people in an equal and reciprocal partnership. If you think about it, all, say for example, supermarkets or big companies do market research. Why do they do that? They want to make sure that more people benefit from their services. In return, they benefit from the profits. So in the NHS, we just need to get so much better at co-designing things. So the college has an equality action plan. You all know this, and I'm not going to go into this because it's there, and many of you would have read it. So the changes that we need to make should always be done with the people affected, and you need to have systems to maintain it. Okay, so 29 action areas. I don't particularly want you to read this slide, but it's to draw your attention in case you forgot. It came out in January 2021, and the action plan goes on till the end of 2023. So I'm pleased to be talking at the CCQI event because my first point is about accreditation systems. So you make sure that you build in measures of equality into your accreditation standards. So in order to be accredited, people need to start thinking about it. So it allows your team or the organization to be much more mindful and build those structures in. The other thing, and we've already done this, we've spoken to the CQC people and given them our advice and opinion about how to integrate measures of equality into the CQC inspection process. I think they've already started doing this. And once organizations understand that this is what they're measuring, they will start paying attention to this. I mean, it's a good way of delivering care and nobody will be complaining about it. Then you tap into other organisations like NHS England and equivalent bodies in Scotland, Wales and Northern Ireland to make sure that you have harmony between the programmes that are currently running. You also make sure that every organisation, healthcare body, for example, social care, housing, you're all collecting high quality data, which is disaggregated. So you actually know which groups of people are getting housing, for example, or who's having difficulties in other social areas. So that's really the strength of doing things. The other really important thing is to make sure that everything you do is embedded into the core of the organization's processes. So once you have that embedded properly, you're much more likely to deliver it in this true spirit that it's meant to do. So organizations will usually have a mission about providing equality or providing fairness or dignity. So you make sure that that's at the forefront. Then you make sure that the organization is collecting data to measure that they're delivering what it says in their mission statement. Then you also produce evidence that they're getting good rating on, say, patient measures or staff measures across different protected characteristics. So, but also to be able to see what good looks like and how is it described. So to have that vision to take the journey forward. And I'm sure this is all of you here as part of the CCQI's Equality or EDI month, and I'm so grateful for you having this five webinars during this month. But to say that quality improvement or continuous improvement program is absolutely essential to drive any changes forward. There is no other magic way. Things are going to be incremental. So for this, you need to make sure that co-production is the thing that sets it off and drives the changes. You start using meaningful data to measure change. You have useful metrics. That's the thing. It should be actually meaningful metrics. Systematic approach to testing change ideas so that you have like PDSA cycles. Then you have a system of learning from your data. And it doesn't matter if things didn't lead to a success straight away, as long as you're willing to examine the data and understand why things didn't work. You get every stakeholder involved. And as things start working, you evolve and scale up things. So continuous improvement model is what you need to use. There are different models. So please be clear that there is a system for improvement for your organization. So if you want to read more, this is a lovely resource produced by the National Collaborating Centre for Mental Health. It's a free resource on the system, and it shows how to identify inequalities and design, deliver, and evaluate. So the good thing is that's about using a systematic process. So it's not just talking about it. The college and the NCCMH are actually delivering practical help. Organizations can register with the AMHI or Advancing Mental Health Equality Collaborative. So we got 17 organizations registered with us in year 1, and year 2 is about to start. So each organization gets a quality improvement coach. We all work together, we learn together. We try and identify for each organization which are the particular groups of people who are affected by inequalities. Then you decide change ideas with the people in the trust. You test them out, and this is a continuous process. It's a 3-year program, but hopefully this type of program will continue. So you have a continuous learning system for an organization, but across the collaborative, there is even more learning. So I think having a proper program which is properly led is really, really critical. So I should finish with Michael Marwood's statement. So I'm saying that it is possible. You do need to have a system. You need to measure it, and you need to believe that you can make the change. So thank you so much for listening to me. I hope we can do some Q&A now.
Raj,
have I stopped sharing?
You stopped sharing. Thank you both so much. That was, I think, Raj, you used the word tour de force, and just the range and the breadth of what you managed to cover and make it accessible, but also not make us feel too hopeless by your latter part, Raj, enabling us to say, look, there are things that we can do. There are sort of some structural things that we can start to shift. I want to give people a little bit more time to ask some questions, but there was one thing that I particularly wanted to pick up, And it's a very personal thank you to you and Laddie, because you were absolutely instructive and helping us refresh the core standards that the CCQI quality and accreditation networks use in order to drive quality and across a huge range of mental health settings. And this year was particularly important because last year we systematically updated a number of the standards to try and make a much further impact on equality, diversity and inclusion. And one of the key things that we were looking at was, how do we really start to get some of the things you were talking to, the disaggregated data, the ability to start to look at the differential experience and outcomes for patients, for example, around restrictive practice. But where I know that lots of teams and services hit a barrier is that we're very, very, very bad at coding ethnicity. And I wonder if yourself or Laddie had, with the work that you've been doing, any thoughts on that, any understanding of why that might be, any sort of advice or tips for people in the audience as to how do we get better at that in order for us to be able to have this disaggregated data that we can then use to improve services. So I wonder if either of you had any thoughts on that one.
So this is actually a very thorny issue, actually. And a few years ago, so it's pre-COVID, there was a general, it's interesting, there were a couple of things. Number one, there were some people who felt like, it doesn't really matter, does it? Makes no difference, a kind of colourblind approach. It's absolutely no difference, we treat everyone the same. So there was that prevalent idea. Second idea that some people had, which was, actually, how dare you ask me about ethnicity? You're trying to use it, you're going to use it in some way against me. And that linked to people then also feeling that it's a bit rude to ask people about their ethnicity, actually, and what they are. Unfortunately, what that would mean, though, is that sometimes people would just write down what they think the ethnicity of the person is and not necessarily get it right. And in fact, or they'd just leave it out altogether. I think because of COVID, people have now recognised that actually you do need to know people's ethnicity. And then because then you can start to see where there are disparities. And I think I showed very nicely that it's not enough to say that someone's South Asian. You need to be able to know the different type of South Asian that person might be, because that will have an impact on health outcomes. It helps you to plan your services as well. So there's much more of a push towards gathering it now. Why is it hard to do so? There are still ideas that, well, I don't know what it is. I don't know what that person's ethnicity is. I don't feel comfortable asking them. And now there's work that's been done to train people to feel more comfortable about asking about ethnicity. And in fact, the best thing to do is just to ask the person how they would describe their own background. How would they describe themselves? And there's been some work looking at the different types of ethnic backgrounds, and NHS England have a long list now. And it's an approximation. It's not great, and particularly in somewhere like London, where there are so many different types of people, that sometimes it does mean that sometimes people get missed out. So, for example, Sri Lankan people often don't get noted in South Asian, that kind of thing. People will get better at it, but the best thing to do is just to ask the person themselves how they would describe themselves.
I do. That's really helpful. Raj, have you got anything to add?
Yeah, I think if there is a lack of enough ethnicity information, the organization should be aware of that. That's really crucial. You can't just continue the same way. So every year, if you find that this information is not getting coded, you do need to look at what the reasons are. Occasionally, people may not want to tell you their ethnicity, especially in mental health, because they don't trust you. They don't want to give you any information. But that apart, if it is a difficulty on the part of the staff and they're not doing it correctly, that can be easily fixed. And this applies across protected characteristics. If you don't do it, you will not be able to help those people. So organizations need to take responsibility, and I think it should go to board level. It should be discussed in their boards if something isn't happening. And if there's so much advantage to be had by just knowing it, you will be in a position to do something about it.
Thank you, Raj. Now, where we've probably only got 3 minutes, and there's been lots of comments in the chat, which have been very helpful. But I wanted to go straight to Prem's question, who says, thank you both for an excellent talk. Raj, you talked about interventions to stop discrimination in the workplace, including CQC-led interventions. Could you say a bit more about how you think this will look like in the future? So how potentially the role of the CQC may be able to be an additional lever to reduce discrimination in the workplace?
Well, thank you, Prem, for asking that question. You know, the how-to and it's the most important thing, really. Like, people sometimes aren't able to visualize. So you do have to start incrementally. You have to start trying things. So interestingly, the CQC inspectors came to my ward unannounced 2 weeks ago. They actually, when they interviewed patients, they asked them directly about experiences of racism. Now, I have been in several wards where they have done CQC inspections before. I don't recall that question ever coming up. So directly asking people how they're treated based on their ethnicity and if they've had any experience of racism. And mind you, I work on a ward with people with a severe mental illness like psychosis, and it's quite possible that people may say things, but you know, it was really helpful that that question is being asked. But they also asked, I think they may have asked staff the same question about their experience. But the truth is, there is a lot of experience, lots of racism in the workplace, and it is revealed by the NHS staff surveys. And you also see different types of data shows. The college has done a survey, we've seen that. What we're trying to do is to do a piece of work around providing guidance for organisations about what to do in terms of tackling racism, preventing it, supporting people who are exposed to racism, and generally educating and having clear policies about actions that can be taken. So we want to do something practical, and this work is currently in progress. Thank you, Prem.
Great, thank you, Raj. And I think hopefully we've got time for one more, because I think this is an excellent question. It might be a tricky one. So for both Ladi and Raj, it's from Massam, who says, excellent presentation in such a short time, thank you. Please would you give an example or examples of services that you know that have had success in challenging, reducing inequality? And if so, what was it? Why did you think that they succeeded? In 2 minutes.
So I can certainly talk about an organisation that we've been working with in the National Collaborating Centre for Mental Health, the Advancing Mental Health Equality Collaborative, and that organisation is Norfolk and Suffolk Foundation Trust, actually. And what they've done is they have a lead, an actual person at senior level, senior doctor actually, who works with other people, and they've identified who has they've identified particular groups in their area. Now we need to see what the longer term outcomes are, but you can really see that it's something that's at leadership level. They've decided, right, we are going to make a change. I also might mention SLAM. SLAM has the SLAM leadership have South London Wolseley NHS Trust have decided that they want to become an anti-racist organisation. They have wholeheartedly, this is over years, not a new thing, been working with people in the local community and developed partnership groups and partnership working groups for each borough that they're in. Now, I think they didn't necessarily have much teeth to begin with, but more recently those groups have started to have a bit of teeth, and it means that the people in the local community have much more input and actually probably better understanding of the way in which the services work. Again, yet to be seen if it makes a big difference to, outcomes, but what it is certainly doing is helping the community to see that the Maudsley is not this big old scary place full of people who are going to hurt them. And I think that's really, really important.
Raj, have you anything to add to that? Probably in 30 seconds.
Thank you, Mary, and thank you, Marcel. Good question. The organization's leadership must put this as a priority. Yeah, they should put themselves accountable for making the changes. And the one thing I wanted to say is that when Adrian James is the president, actually held himself accountable. So as he finishes his tenure, it's time for all of us to ask him what he's achieved. And that's the kind of accountability you really need. no one's going to, punish you, but it's about owning the process that you've done. It may not have given the results yet, but if you have embedded some of the processes, you stand to gain from it in future and modify it.
Thank you, Raj. And I think that's also a very straightforward thing that people can take forward to say to their leadership, what are you doing, and how will we know that you've achieved it? I wanted to say an enormous thank you to you and Ladi. That was an absolutely superb opening session with really sort of concrete ideas about what we can do, but also me personally seeing the map of the UK with our depression and anxiety literally replicating what our variable deprivation levels look like. That's something that I think maybe many of us on this call will take away. So thank you both. We've got, I said, a whole month of webinars and resources coming on EDI. We've got different topics. The information that you heard today, the recording, will make slides available. We'll get in touch with you through a newsletter. And so we look forward to hopefully continuing this conversation over the month. And Ladi and Raj, thank you for your leadership and example in this area and for helping us try and progress. And I hope everyone has an excellent evening. Thank you and goodbye.
Thank you.